Hello and welcome to today's Upper Midwest Telehealth Resource Center webinar. My name is Becky Sanders. I'm the Program Director for the Upper Midwest Telehealth Resource Center. And today we are going to be learning about virtual care pathways and how telehealth fits into that. We have two speakers with us today, Margaret Kirkegaard and Nancy Kamp. Before I hand things over to them, just wanted to let you know we are recording today's session. We will be placing the video on our YouTube page and also archiving a link to the video as well as the slides on our archived webinars page on our website at umtrc.org. Everyone is in listen-only mode today. You can use the Q&A function on this Zoom meeting to ask questions. And we will hold all questions until the end. If you're having technical issues, then I encourage you to use the chat function and chat with Carolyn Miller, and she can help you with technical issues. So without further ado, Margaret and Nancy, I'm gonna turn things over to you.
Thank you. Thank you for that introduction, Becky. And we are delighted to be here today with the Upper Midwest Telehealth Resource Center. And welcome to all of you who are taking time out of your busy schedules. We know that it has been tremendously busy and often very stressful for the last few months. So we appreciate your time and attention today, and we look forward to talking to you about virtual care pathways, which is a new effort by Health Management Associates. Just a brief introduction. For Health Management Associates, we're a national research and consulting firm across the United States focusing in publicly funded healthcare and resource-scarce environments. We spend quite a bit of time doing delivery system redesign work, helping those resource-scarce environments thrive in a publicly funded environment. These are our objectives for today's session. We're going to describe the imperative challenges and benefits of telehealth services. I think many of you are probably aware of that because you're already connected to the UMTRC, but we'll briefly describe what we see is the context for development of the virtual care pathways. Then we'll describe the benefits of the clinical pathways and opportunities to modify them to support virtual care. And finally, we'll describe the potential applications and implementation strategies so that you can take some of these lessons learned into your own clinical environments. I'm Dr. Margaret Kirkegaard. I'm a board certified family physician and have worked at HMA for 7 years. Prior to joining HMA, I was the medical director for our statewide Medicaid program in Illinois. I've worked with multiple practices and clinical environments, adapting telehealth and developing pathways to integrate telehealth into their care environments, ranging from telehealth in the ICU and telestroke in the emergency room, all the way down to primary care using telehealth for triage and behavioral health environments. And I'm joined today by my colleague, Nancy Kamp, who will introduce herself now.
Thanks, Margaret. Hello, everyone. I'm Nancy Kamp. I am out of the HMA Phoenix office, although I was in the Chicago office, and I'm a Midwest girl most of my life. I'm a nurse by training, and I have also been with HMA for 7 years. And my primary work is really in the primary care medical practice situations, working with complex care management systems, PCMH models, patient-centered medical home models, health home models, and integration of behavioral health and primary care. With all of that, in the last, for sure last year, but even last couple years, telehealth has really become a cornerstone within primary care in how to offer that to patients and how to use that in a very engaging and effective way. So that's been certainly a big focus for all of our PCMH and collaborative practice transformation type of work. And I'm excited to be here and talk with you all this morning, or today. I guess it's morning for me in Phoenix, sorry. All right, okay. Thanks, Margaret.
Thank you. All right, So we are obviously in the middle of COVID, and as Nancy said, HMA was working very much with telehealth as an enhancement to a variety of different care environments prior to COVID, but COVID has accelerated and impacted so many things, and particularly our use of telehealth. And while we think that not all of the regulatory flexibility that is currently been enacted to support telehealth will remain, we don't think that we're going to go back to the environment we had before. And that's clearly CMS has come out with some statements supporting that. Just briefly to remind us where we are in the COVID trajectory, we had the emergence of COVID back in March and the national state of emergency declared. I don't know for all of you in your states, but here in Illinois, we had to, all of the hospitals were put on lockdown, all elective procedures were suspended. So it had a tremendous impact, even if you weren't one of the hospitals scrambling to care for sick patients in your ICU and running out of ventilator beds, then you were impacted by the fact that you had no patients, or patients who required care had difficulties accessing care. Then we had our emergency response, and God bless everybody who worked so hard in those months in April and May to prevent the morbidity and mortality. Then as we saw over the summer, we really began to reopening systems. Hospitals developed their programs for infection control. Nursing homes did a better job with infection control. Primary care did a better job allocating which patients are going to go to respiratory clinics and determining how to manage segregating the COVID patients from the non-COVID patients. And now we're really into more of a second wave phenomenon, even though we may have had a second wave in the summer, but we're over here now where we're trying to stabilize our lessons learned and figure out what the new normal will be and work on supporting vaccine campaigns and other aspects of the COVID response. But all the while we're building our capacity and managing COVID patients, these things are going on with provider revenue and economic stability, particularly for under-resourced environments to begin with, or rural hospitals, and workforce attrition. Many people were laid off or they were retrained during the tremendous phase during March and April, but now people are just getting tuckered out. And so our work is to try to address both the upward trajectory of COVID, how can we prepare, yet at the same time prevent this downward trajectory of provider revenue and workforce attrition. Prior to the pandemic, however, we were working very much in delivery system design and the integration of telehealth. We know that patients want convenient and timely access to care, and they want quality care and affordability. So as consumers, we traditionally in the United States want everything. But patients are willing to give up a little bit in terms of continuity of care for convenience and access to care. Payers want the providers to take accountability for population health outcomes, but we know that puts our providers in a little bit of a double bind when patients also want this timely access to care and may prefer to go to an urgent care center. And then you're actually, as a primary care practitioner, still responsible for them. And we know that we have a lot of disruptive innovation going on with Walmart developing their primary care model and kiosks developing. The outside capital is definitely investing in disruptive care models using various technologies that are really outside of traditional healthcare settings. We're seeing artificial intelligence used for CBT and monitoring for chronic disease patients. The hospital at home model is emerging in many rural places. So we've seen tremendous integration with vertical and horizontal integration, and big data is really coming into the foreplay. I think that we haven't seen as much of the promise of the EMRs and the HIE as we thought over the last decade, but I think it is slowly emerging to be a force to get all that information together. And finally, providers are payers and other entities, patients want providers to be accountable, both clinically and financially. So there are tremendous drivers that are impacting all of you. And I probably didn't need to list all of these in great detail because you're living it day in and day out. And then we have COVID layered on top of what was going on in the pre-pandemic world. So hospitals were afraid of running out of beds, but the rest of the healthcare system was afraid of running out of patients. And we have a lot of pessimism among our physician community that this is really going to impact them. It has impacted them. A lot of people have given up revenue or failed to take a paycheck while they're supporting their staff, or staff have been temporarily furloughed. And we just know that things are not ever going to be the same as they were prior to COVID. Our care pathways were developed primarily for the primary care environment. However, we think they're adaptable, and the process of developing the pathways is definitely adaptable to any clinical environment. But just focusing for a few minutes on what was happening to primary care, or what is happening to primary care, is we know that primary care visits have declined. So patients are using less primary care in general than they used to be. And problem-based visits have also declined. So people are not visiting their doctor as much as they used to. And the portion of adults with no PCP visits in a given year has risen. And the visits to alternative venues has increased by nearly 50%. So we know that patients are choosing access and timeliness, and for example, Amwell and some of the other telehealth services over a visit to their primary care provider where they might have to take a full day off of work. And we as primary care and other clinical environments need to adjust to that growing consumer demand. So focusing on adapting virtual care. Virtual care is in fact one of the ways to adapt to that changing consumer demand. And while we had some flexibility prior to the pandemic, this has really raised the bar and allowed us to experiment much more broadly and take advantage of this flexible regulatory environment so that when things get back to a new steady state, everybody will be well prepared to maximize the opportunities created by COVID and not just survive through the process. We know that there are new payment mechanisms that have made it possible. Not all of them will remain, but I think a lot of them will. I think HMA is making a lot of predictions that they will remain in place. CMS has definitely recognized the importance of providing partial or full primary care capitations. So CMS is still committed to moving towards value-based payment environments across the board, but particularly for primary care. And as we've said, patients prefer this, and everybody's really trying to assess the value of virtual care. You know, there's a concern that maybe virtual care could potentially drive, if you have a virtual care visit, and then it would drive extra emergency room visits because the virtual care provider says, well, you better go to the emergency room. On the other hand, virtual care can substitute for a unnecessary emergency room visit. So we're recognizing that virtual care has its place, probably a bigger place than it had prior to the COVID pandemic, but it has to be done in an intentional and value-based way. And that's precisely what we've done to try to take our virtual care pathways. So what's in it for me, the WIFM, for focusing on adapting virtual care? So many primary care offices are just struggling to get by in this scenario. But as we said, we think there's an opportunity to really take what's happening, develop some great clinical practice models that are linked to quality of care. And when we're all raising our heads again, a little bit out of the very heat of the pandemic, that we'll be able to offer these to payers and have a solidified process. So this applies to primary care and behavioral health, medical specialists, but we think it also could apply to in acute care environments or the nursing home environment. The goal here is to develop these virtual care pathways that are grounded in clinical practice guidelines and solidified in the clinical practice environment as a new normal. In order to do that, we need to develop new skills among our team members and our competencies. And patients will require different kinds of supports. Instead of having them come in to discuss their hemoglobin A1C, then maybe we provide them with a telehealth visit from a clinician who's going to discuss their medical management, and with a health coach who's going to discuss their nutrition and behavioral choices around diabetes management. Of course, those are going to require new payment models, and we have built our virtual care pathways with the intention that you can work with your payers to support these pathways in a new payment model. All right, so a lot of us have been doing the challenge of transitioning to value-based care for the last 10 years by integrating behavioral health and doing many, many things, transitioning to patient-centered medical home models. But this is to take everything we've learned in the last decade and then reapply it to the telehealth environment. So as I said, using a guideline-based approach, using a population health approach, so selecting what are your most common conditions and developing routinized regular pathways, providing education, health education and routine monitoring, and using our team more effectively, not just having our MAs room patients, but really take advantage of that process. Motivational interviewing and skills. We know that about 50% of chronic disease management really comes down to patient choice and behavior. And we need to do a better job of intervening with our patients and helping them get to healthy behaviors. And then using different tools and screening instruments in order to stay on clinical pathways so that we actually can have outcomes that we can bring to our payers and improve our value. Okay, and with that, I'm going to turn it over to Nancy to follow up here. And Nancy, just let me know when I need to advance the slides.
Thanks, Margaret. So I'm going to build off of what Margaret introduced here and get us more into some of the specifics of the virtual care pathways and how they could look and how we can implement such things within our primary care settings. So kind of building off of the last slide that Margaret just showed, don't advance it quite yet. So building off of the last slide she showed about, kind of what we've been doing in the past, but how can this actually still drive the future? And there are a lot of similarities between what we've been doing in in-person care and what we need to do in virtual care. There may be tweaks, there may be some additional ways to think about these things, but there are still a lot of consistencies between that. So things like engagement skills and building relationships with patients. We all know that relationships is the key piece to primary care adherence, to treatment plans, and better outcomes. Well, those types of skills on outreach and engagement and building relationships is going to be the same, if not more important in a virtual care setting, because we need that relationship as a starting point to be able to continue care in a virtual way. So there may be some more skills, some more training, some more competencies around engagement in a virtual world, but that key component of skill and approach of relationships still has to be there in the virtual care approach. Use of clinical skills. We still have to do clinical skills. How do we do that in a virtual way is the way to think about this. And we'll talk about this a little bit as we go into some of the details of the pathway. Screening and assessment tools, Margaret talked about that. This actually gives an opportunity to keep up better on your screenings and your repeat assessments, because you kind of have someone captured, like a captured audience when we have them by video or by phone, and we can assess, and repeat some of these assessment tools needed. Identifying critical areas and setting goals with the patient. So care planning. Care planning is the crux of office visits right now. It's the same in virtual care because we still need to care plan. We still need to engage patients even more so in self-management and setting self-management goals, and then following up with the patient on those self-management goals. So still is a very critical, consistent approach. Summarizing the visit and follow-up. Any of you who are patient-centered medical home know the importance of the visit summaries and then following up after, and kind of that follow-up in between provider visits. So we've talked about around patient-centered medical home, in between the face-to-face provider visits, that we do telephonic follow-ups. We do care management and care coordination follow-ups. There's no difference in that now in the virtual care world. So if a patient does have a virtual care visit with their provider, the reasoning and rationale to still have a follow-up phone call in between those virtual care visits is still there, is still necessary, and keeps patients engaged and working towards those goals in their care plan. And then, of course, documentation of the visit is no different in the virtual world as it is in the in-person world. So these might be common sense as you think through these, but we really took a step back and thought about where there are so many similarities, that this is not as far off of a concept as one may think, and that we need to really reflect on these commonalities and say, okay, we need to continue to use the good skills, the good practice, the good processes that we've been doing along the way. No, you can go to the next slide. That's great. So, so what does virtual care look like? Well, we have four topics, four chronic conditions here that you see that we focused on first, and I'll let you know why we chose these four in a second. But when we look at these four topics, we've basically created sort of a toolkit for each of these to implement in a virtual care world. Our toolkits include things like the virtual care workflows. So actually from start to finish, you're connecting with a patient or a patient connects with you all the way through to the end of that visit and maybe even post-visit care. What does that workflow look like? All of our workflows are based on the evidence-based guidelines in these four different condition areas. There are patient engagement and communication tools. Again, very similar to engagement tools and communication tools you may already be using, but there may be a slight tweak to how we engage people in a virtual manner. Patient education, intervention tools, and self-management is still going to be an important component in virtual care. Staff roles and the skills needed. So we did a lot of work on our workforce. What does our workforce look like or change in a virtual care setting or telehealth setting? And then training materials to help train care teams on these new kinds of methods. So to go to the next slide, this gives a little bit of concreteness to why we chose these four topics. And we're not also saying you only can focus on these four topics in virtual care. There's all kinds of topics you can focus on in virtual care. But when we think about primary care, these are kind of the four most prevalent presentations that we get from patients in primary care, and really wanted to focus there, not only because of the prevalence of it, but also there's really an under treatment, under management within these topics. So I may be preaching to the choir here a little bit, but I wanted to just highlight a couple key statistics on each of these topics. So diabetes, we know this affects a large number of people. 34 million people in the United States are affected by diabetes. In our F2HC world, and we're able to look at these data through UDS, so that's why we can pull these data and look at it more universally. But 33%, over a third of the patients with diabetes are poorly controlled or have had no test, so essentially are not being managed. In asthma, we know that more than 60% of adults with asthma are uncontrolled. And when we look at the cost of untreated or not well managed asthma, the cost on an annual basis was $81.9 billion, which was including medical costs, but also quality of life, right? Loss of work days, loss of school days, etc. Depression and anxiety, the numbers, and obviously the numbers are growing even higher now, post-pandemic or during the pandemic, but over 8% of American adults had depression in any given 2-week period in 2013 to 2016. The most staggering statistics on depression are that when they are coexisting with a medical condition, and there is so much literature on this, showing depression coexisting with all different kinds of conditions: diabetes, hypertension, cardiovascular, asthma, arthritis, and the list goes on, and it shows the increase in total medical costs when that depression is coexisting with a medical condition. Again, this may be, kind of a no-brainer as I'm saying this, but these numbers are really powerful and powerful for supporting our need to focus in on these topics first and foremost, and that these topics can be well focused in on and well implemented in a virtual care way. Last stat on the depression, that over 28% of those screened positive for depression received treatment. Only 28% received treatment. So 3/4 are not receiving any kind of treatment. And we probably are all aware of that as we are faced with this almost on a daily basis. Hypertension, around 11 million people have blood pressure that is too high and they don't know it or are not receiving any sort of treatment. And only 1 in 4 of adults with diagnosed hypertension have their condition under control. So we have lots of opportunity here to focus in and not forget that in a virtual care way, we can approach these conditions and really work at management of them and engaging our patients in self-management at the same time. So let's go to the next slide. And on the next slide, this outlines a little bit more of what HMA's process was for developing these toolkits. So first of all, we decided on the topics, as I just talked about, kind of that rationale. And then we started looking at what is current process, what is the current ideal process with in-person care, so kind of usual care. What does that process look like? And then looking through those steps and deciding which of these areas can be done virtually. Clearly, we can't draw blood virtually. So there are certain things that we know can't be done virtually. So let's look through our processes, decide what can be done virtually, and then how can we create new workflows based on those things that can be done virtually, and understanding when there needs to be deviation from that virtual care pathway because someone does need an in-person visit or a diagnostic test, etc. We then compared and analyzed the best practice guidelines for that topic to make sure that there isn't anything within the practice guidelines, the evidence around these guidelines, stating in-person versus virtual. And there really isn't a lot of that. And there's a lot of significance to steps in those best practice guidelines that say, you know, this is what is best practice. That's totally doable in a virtual care world. So we really sort of overlaid those best practice guidelines on our virtual care workflows. We wanted to make sure that we are linking outcome metrics from the virtual care workflow, linking it to outcome metrics and metrics that make a difference to both patients and payers, right? Because we know if we are going to want to talk about new payment approaches and new payment methodologies or new value-based contracts with payers, we need to be able to show them that our virtual care pathways are going to get the results that they're wanting and needing as well. So we have within our toolkits sample measurement sets for each of those 4 conditions. Again, keeping in mind what would payers and patients be looking for outcomes. Team approach. We really spent a lot of time because in virtual care, it is, you know, again, in patient-centered medical home in general, we talk about team-based care, but team-based care takes a whole nother level of meaning when we think about our virtual care approach, because we really want to look through each step of the pathway to say, do we need a provider to do this step, or is there someone else on the care team that can follow up with the patient in a virtual way and do this step, whatever that is. So really thinking about the team approach was a goal in our pathways, and we'll show you some examples, but we actually created what we call swim lanes, which is a lean tool for workflows. And in those swim lanes, we actually listed out each of the care team members and then what their process is goes across in each swim lane. So there's, you know, your provider, your medical assistant, your, you know, registration person, whomever is on your care team. We listed those out, listed their process, and then how those processes hand off to one another. And so in addition to just a workflow, we've also done that swim lane to help support that team-based approach to virtual care. Integrating adaptations for telehealth versus primary care. We have a lot of telehealth assessments and tools for implementation, and to say what needs to be adapted there for these kind of primary care virtual care pathways. And we have tools and resources within the toolkit on that as well. And then developing tasks for each care team role that focuses along that swim lane that I was talking about. And then creating pathways with contingencies, the what if, right? Because not everything works exactly the same way from day to day or from practice to practice. So having those contingencies in place. Oh, you can go to the next slide. I was trying to change the slides myself. Okay, so what does the new normal look like in this virtual setting, okay? So, so when we think about the virtual care pathway, one of the things it's going to start with is more than likely it's going to start with some sort of triage encounter, using some sort of criteria to determine, does this patient and what they are needing right now, does that need to be a face-to-face visit, or can this be done in a virtual pathway? And so having that kind of determination or some type of criteria, and whether that is happens when the patient calls in to make an appointment. Maybe that's built into your electronic systems. If you have patient portals where patients can actually make appointments online, can that criteria be in that, and that logic kind of be in that electronic resource? So there's different ways that can happen. But the bottom line is probably every encounter starts with that. Then we think about the team-based approach to the actual pathway or workflow. And it's going to be something, if we think about what happens in a traditional way, how that converts to a virtual way. So is there a medical assistant or someone who is calling that patient, checking vital signs virtually? And what do we mean by that? Well, think about there's a lot of push now for patients with hypertension should have a blood pressure home monitor. And actually, a lot of people at criteria for different age ranges, other coexisting chronic conditions should have a blood pressure home monitor and be checking their blood pressure and can be relating that to their provider. I don't have hypertension or diabetes, but I have a blood pressure home monitor at my house. And if we think about how things are going to change, that may be the new norm. There's a lot of pharmacies. I work with Walgreens nationally that has a program that are giving out blood pressure home monitor devices if their PCP signs a form for them, and they don't have to have a diagnosis of hypertension. So there's a much bigger push for some of these kinds of ways to do some of this in the home. There's other things of people, taking their temperature, taking their weight. They can verbally report that to that medical assistant, or there may be other digital ways to get that data to their primary care provider. So we can talk more about some of these specifics. I don't want to get us too much down a rabbit hole. But the point is that we still can do some of that vital sign checking virtually. We can also be at that initial medical assistant checking with the patient. That's where we can do some of the structured assessments. Does this patient need a screening PHQ-9? Do they have a diagnosis of depression, so we should be repeating the PHQ-9? Have we done a health risk assessment in the last year? We should do that. So it's a way to kind of plan for this visit and do all of those prep assessments and checklists ahead of time. Doing a medication review is no different. Reviewing the medications with the patient, asking the patient how they're taking their medications, checking refill history online, all of that can be done in a virtual way. Then there's a handoff to the provider, and the provider will complete the remote visit, supporting whatever needs to happen, population health, preventive screening dashboards, care gaps, all of that kind of thing can be done in a virtual way by that provider with the patient. And then at the end of the provider visit, there's another warm handoff to another team member to maybe do that follow-up, do a visit summary, talk about the follow-up, schedule the next appointment, whatever needs to happen at the end of that appointment. And I'm going through this pretty quickly. There's a lot more detail of this that's laid out within the pathways. So you can go to the next slide. And the next slide just gives a little bit more detail to what I was saying. So things like before the visit, how do we kind of plan for that visit? So again, there could be digital self-scheduling. So if you have those kinds of electronic portals, there are things that can be done in an automated way. Again, looking at refill medical history or filling the medical history in there, prescription refills, getting reminders. What are the pre-visit, tasks that need to be done? So is the patient due for a hemoglobin A1C? How do we do that so that at the virtual care visit with the provider, that we actually have that result of that test? And there are, lots of innovative things going on right now with mobile labs and different ways to get the lab tests you need or other diagnostic imaging and et cetera. Now, I want to say here, some of you may be looking at this and say, well, I don't have any of that. We don't have a portal. We don't have any of the digital ways to doing this. Even if you don't, you still can do successful virtual care. You just have to modify and adapt your workflows to fit what capabilities and what accessibilities you have. So this is just sort of giving some examples of this, and the toolkits are really a starting point. They're not the be-all, end-all answer for every single primary care practice, but it's a starting point to help think through and assess your own organization's capabilities, readiness to do this kind of work. So anyways, so there's before visit things, again, the during the visit, and then there's post-visit options, again, of, remote monitoring, post-procedure tasks, telehealth care management follow-up, all those kind of things that we've sort of already talked through. So let's go to the next slide. I'll kind of go through these last ones to finish up here. This gives, this slide is obviously terrible to look at as far as if you want to read the detail, but we wanted to at least show you an example workflow. This one is specifically patient registration and intake workflow, and it is, again, in that swim lane visual where you see on the left-hand side, patient screening, pre-visit planning, patient virtual appointment, and then it lists and then it shows the process going across from left to right. That's what we call the swim lane process and workflows. And then you see how each swim lane connects to the next. So this is just an example of one workflow on the patient registration. If you go to the next slide, we have additional examples of workflows that are within these toolkits. So this one is the hypertension screening workflow. There's also a hypertension management. So we have in all of these in all of these conditions, diabetes, hypertension, asthma, and depression, anxiety, we have screening workflows and then management workflows. This, again, this is the same thinking as if patients were coming into the office. There are processes and policies that you have for when do you do screening, for universal screening for every patient. When do you do or how do you do management of someone who has the diagnosis? So we followed that same kind of thought process again, but within the virtual care world. And almost all of your screenings and screening tools and questions can be done in a virtual way, and much of your management as well. So these kinds of tools list, again, the workflows, lots of different types of workflows, and then supplemental resources and tools to help support those workflows. So things like engagement tools, communication tools, that kind of thing, to support the virtual care workflows. The next slide. This, the last couple of slides I have here move us into another aspect that Margaret touched on briefly, but is an important aspect when we think about getting ready and our readiness to do these virtual care pathways, and that is what is our payment models. And one of the first slides Margaret walked through said, virtual care pathways can be implemented whether you're in a fee-for-service or some type of value-based contracting or capitation payment model. But you have to know what your payment models do look like in order to successfully implement the pieces of the virtual care models. So really thinking about in a fee-for-service world, if you're using a lot of your other care team members to do some of this virtual care workflows, those aren't billable services. But how much time and efficiencies are you gaining in the time that the provider themselves, the billable provider, is spending with that patient? And how many more virtual care visits could that provider possibly see? If you have models that have some fee-for-service, but also maybe some capitation or value-based contracting with it, that gives you an opportunity to do some more of that team-based virtual care approaches and get you even further towards some of those patient outcomes. And thinking about to the right side of that cake here, to pay for performance and shared savings contracts with your payers, care management fees with your payers, if you can show how you are very much focusing on the whole care team approach and using that care team to really engage the patient in their management of these chronic conditions. If you go to the next slide, this is also a bit of a busy slide on the right side, but we just wanted to show you also that we have created sort of a model template for financial modeling. And again, this isn't necessarily rocket science, but it's an important point for us to say that if you're starting out or if you're enhancing your telehealth to some of this virtual care pathways, you really want to use some sort of financial modeling as a part of your implementation to see what is the cost of this care and how do you adjust or make changes or utilize this with your payer contracting discussions as well. So thinking about what's the type of payment model you have currently or payment models, what are the costs, which we have these modeled out for those 4 conditions that are based on estimated time of different types of staff doing the different steps of the workflow. You may be including technology solutions in your financial model, depending on, do you have a portal? Do you want a portal? Do you have a EMR that interacts or not? The different technology pieces will drive your financial model in different ways. And then really that this financial model is fully customizable and needs to be, because again, what we've said, one size doesn't fit all for these types of models and pathways. They have to be adapted to where you are in your practice. So let's go to the final slide, I think, which is the next steps or how to get started. And this is just like a list of things to think about that you could do within your own organization. These are not in necessarily sequential order, like time sequence, except I would say the first one, which is assess your current telehealth capabilities. And that's really the place to start if you haven't done something like that, is assess your capabilities and your readiness to do some of this work. And then that assessment can help drive what are your next steps to adapt and implement clinical models, secure remote monitoring devices, looking at ways your EHR interfaces with patient information. Do you use data to drive your population health, and how could that be done in the virtual setting? Clinical decision support capabilities, the development of your workforce, where are their skills? Do they need some more training? And then your financial modeling and leveraging your payment. So this is a big list, but these are ideas for you to think about as you either, as I said, get started or enhance where you've already been. I think with that, I'll close out. And we are ready to, I think, open up for any questions, comments, or discussion.
Thank you so much, both of you. I love, I've got my black belt in lean healthcare, and I love all the references. I think that lean and telehealth really go hand in hand. So now's the time for questions. You can put those into the Q&A, and we will answer those here. And while you're thinking of questions, I am going to go ahead and send out the survey. And it's just a couple of questions. This helps us to plan for future webinars and also give feedback to our presenters for today. So please complete that before you leave.
And if no one has questions, but would be so inclined to chat in where your organization is at in terms of telehealth, virtual care, you know, any thoughts or reactions to that from what you're currently doing. We would love to hear what you're currently doing or where you're currently at.
Absolutely. I know we've seen a lot across our 4-state region of Illinois, Indiana, Michigan, and Ohio. A lot of companies look at telehealth for the very first time with the COVID pandemic. Many, you know, I talk about our region and the Telehealth Resource Center's role in that. It felt like for a long time we were a little rowboat in the middle of Lake Michigan. And then all of a sudden there's COVID, and we felt like we were a cruise ship with everybody that wanted to pick up telehealth and to streamline their practices and make them you know, just as compliant and clinically proven, but using telehealth methodologies.
Definitely true, Becky. We're seeing that across the United States, and definitely the need then to take this opportunity to capitalize on this, however difficult it is in the middle of COVID, so that when the regulators come back to assessing, the cruise ships are all sailing, and they're sailing in the right direction, and they're showing value as opposed to looking like the Titanic. And so we need to really capitalize on that.
We do have a comment in the chat. Juan from Cincinnati is trying to find out how best to support providers looking to implement telehealth.
Well, I think that depends on their telehealth environment, where they are and what their payer mix is, of course. I think it starts with an assessment of what telehealth capabilities they have, what their payers are, what the regulatory flexibilities are, if their payers are allowing telephone only visits. I mean, if you're in an environment where you're able to bill for a telephone only visit, then that's a way to just dip your toe in the water without really having to do anything extra. All clinical environments have a phone, and you can really get a lot of information from patients in management just talking to them on the phone. So if they do like Nancy does and goes to the drugstore and gets their blood pressure cuff, and then you talk to them on the phone, you can do quite a bit of hypertension management just with that. And so definitely helping providers be creative to break out of that fee-for-service, see your patient in your office mode, get a payment.
Yeah, absolutely. We get a lot of questions at our TRC about equipment that a person, an individual would need at their home to do vitals, you know, things like thermometers and blood pressure cuffs and pulse oximeters. Are you guys seeing any movement towards either insurance companies or large groups of providers purchasing that equipment for patients to keep at home?
Yes, definitely. I can't speak so much to providers or insurance companies. Maybe Nancy can do that. Although many insurance companies will pay for a blood pressure cuff if you have the diagnosis of hypertension. And of course, many people already have a glucometer at home. And most people have a scale at home. They don't think of that as a medical piece of equipment, but it's an important piece of equipment for many of our chronic illnesses. And so people already have a lot of the equipment that they need at home. I'm working with another group now on telehealth OB care, and we are sending the Doppler kits, the Doppler devices to pregnant women so they can measure their own fetal heart tones and instructing them how to measure their fundal heights. So there's a lot more that we can do to empower our patients to collect this information than we have historically. And even in some environments, we're also seeing home visits to draw blood or to pick up a stool sample so that you can do your colorectal screening with your FIT test. And patients don't even have to leave the house and carry their stool sample around with them. They can just provide it for the person collecting it.
Nancy, did you have any comments? No?
Oh, okay. Honey. Nancy.
Sorry, I was trying to be quiet and then I forgot to take off mute. Yeah, just reiterating what Margaret said, totally. We're working with a lot of actually health plans that are supporting getting blood pressure cuffs, glucometers. There's some of them have programs with patients with CHF where they're giving them scales, and it's a specific scale that actually has Bluetooth technology. So the weight is automatically sent to a care manager every morning when that patient steps on the scale. So there's lots of technology, things like that are growing, and if you can, like, as I was mentioning, like Walgreens nationally is doing this kind of blood pressure home monitor push. And so if you look into those things a little bit, you'll find either nationally or within your own community, those kinds of resources that you could institute, with your patients.
Very good. Well, we are at the end of our time. I want to thank you all again for being with us today. And hopefully you had time to complete that short survey, and have a great rest of your day.
Thank you. Thank you for inviting us. And
you're very welcome.
And
for those of you that registered for today's event, we will be sending out an email once the video and PowerPoint slide deck or in a PDF version are posted on the website. So thank you.
Thank you, Becky.
Have a great day.